It's a pleasure to be here. I just really support this group and the doctors and leaders, the directors of this organization. I'm amazed at what this group of people have been able to do for these disorders, and I just really take my hat off to them. This is obviously an unmet need in the community, and so it's a privilege to be here and to be with you today. We are talking about jaw disorders, and you know, it's difficult to cover this subject in an hour's time, but we're going to do our best to do that, and I'm going to try to give you some self-help things you can use, some resources you can use, and to try to give you some things that you can take home. And we're losing me. We coming on now? Okay. All right. We'll get along. There's a tremendous amount of confusion, misunderstanding, misinformation about this topic. You can go to, as you may know, it's only dentists that treat this condition. Physicians, as a matter of course, don't treat this condition. And you can go to 10 different dentists who profess expertise and get 10 different diagnoses for this condition. Very frustrating. And in fact, it's the biggest frustration of my career in terms of there not being better unanimity and understanding in this field. But that's still where we're at. And I'll try to talk about some reasons why there's so much confusion, even among the physician, or even among the dental community. So I'm also going to touch on the connection, if you will, between jaw disorders and fibromyalgia, because many of you are here with that condition as well. Let me dispel one myth, and that is that TMJ is not a diagnosis. So if your doctor tells you you've got TMJ, that just tells you that you've got a jaw joint. It doesn't really give you a diagnosis. And so there's been this whole constellation of symptoms that have been attributed to jaw disorders, many of which have nothing to do with the jaw at all. To compound that, the internet has been with us for 10 years now. There's hundreds of thousands of sightings on the internet for jaw disorders. Many of those are personal opinions, have nothing to do with research or science or anything else. So it's easy to get misled even on the internet today. Typical symptoms that we see with this constellation of problems is obviously jaw pain, also headaches, neck and shoulder pain, ear pain, clicking and popping of the jaw, and jaw restriction. That's sort of the order of frequency of complaints that come into our office for patients presenting for diagnosis and treatment. Some clinical features: we have a 90% female predominance. At least 9 out of 10, it's probably closer to 93, 94% are female. Nobody can really give us a direct answer to why that is, but one thing I do know, it's not because females have a lower pain threshold or they're not as good at copers as males are. In my opinion, females are much stronger when it comes to dealing with pain than males are. So it has nothing to do with tolerability of pain, but nevertheless, females are primarily what we see. For ages, there's two different really conditions, and I'm going to primarily limit my talk today to jaw disorders, what we now call TMD, or temporomandibular disorders. There's a less common problem that we also deal with that has to do with what's called orofacial pain, which is more of the neurological complications that some people get involved with. That's what the OFP stands for there. For jaw disorders, it's primarily young people from age 14 to 40 are typically what we see. Family history is important. These things often do run in families. And symptoms, one of the confusing aspects of this is that symptoms often lag trauma by many years. One of the principal causes of this disorder is childhood trauma prior to the age of 10 or 11 years old. What we think happens is that trauma to the jaw somehow injures the jaw joint itself, primarily the ligaments of the jaw joint, and they never do grow and develop normally and eventually break down to the point that we have derangements of the jaw joint. And it's usually associated with other problems, and I'll show the reason for that in just a second. There are other oral symptoms that often present with patients having fibromyalgia that you may want to be aware of. Xerostomia is dry mouth, and many of you have been dealing with that. 71% of fibromyalgia patients deal with dry mouth. Glossodynia is a burning of the tongue, or at least a pain in the tongue, but often it's a burning sensation. Jaw disorders, more than 3/4 of fibromyalgia patients typically also have some jaw complaints. Dysphagia is difficulty swallowing, and dysgeusia is an altered taste, often a metallic taste in the mouth, or sometimes a total lack of taste altogether. So what is TMD? Well, it's really an orthopedic problem. It has to do with the joint, with associated ligaments, muscles, nerves of a joint. And so really it should be the orthopedic physicians that are dealing with this, but typically they don't. There is no typical TMD patient. I spent an hour and a half with a new patient. Most of that time is making the diagnosis, taking very thorough histories, doing a physical examination, taking specialized tomographic x-rays, and no two patients are treated exactly the same for reasons I'll show you in a minute. And jaw symptoms often have other causes. Many times patients come into my office saying, I have pain right here in front of my ear, and there's no problem in their jaw at all. All of their pain is referred from their neck or shoulder or some other area, and so I'll be referring them to somebody else. I only recommend treatment myself to about half the patients that I examine and diagnose. So here's the reason why. Jaw disorders really involve everything you see on this slide. And the reason for that is because the movement of the jaw, the positioning of the jaw, has everything to do with the positioning of the head. We have a sphere here about the size and weight of a bowling ball that's suspended on a very flexible pole. The only thing that keeps our head in balance and erect is the difference in tension between the muscles of the neck and the jaw itself. So if you want to open your mouth, you have to relax these jaw muscles here and contract these muscles in the neck in order to bring the jaw open. And so chewing, any movement of the jaw also affects all of the muscles of the head and neck as well. The reason some dentists get involved with this is because the way the teeth mesh together here has a direct effect on how this joint positions itself. Because when the teeth come together and mesh, that's what positions the lower jaw, called the mandible, relative to the skull. And that's what positions the ball in the socket. Conversely, if you have, let's say, arthritis in the jaw joint, oftentimes that involves a bone loss. In some cases we see patients coming in where virtually all of the bone that forms the ball of the joint is gone. It's degenerated, it's eroded. And that dramatically alters how the jaw hinges and adversely affects how the teeth mesh together. These folks have great difficulty chewing, eating, using their jaw for much of anything. This is a unique joint in terms of its structure as well. This joint is different than almost any other joint in the body because the covering, the surface covering of the bone is not a hyaline cartilage. Most other joints in the body have a very inert hyaline cartilage that's very tough and durable. The surface covering of the jaw joint is a fibrocollagen which has cells in it, fibroblasts, and those fibroblasts can differentiate into cells that can either grow bone or resorb bone. And so the shape of the jaw joint can change throughout life. And so that's one of the unique things. In addition, this is a joint that has a very dynamic movement because it has to function with a pair joint on the opposite side as well as with the teeth. And so it's a very complex movement that the joint goes through. This is just an x-ray showing you, this dark circle here is the ear canal. You can see how close the joint is to the ear canal. This is the ball here, the socket. This is called the eminence of the joint here. And that space you see between the ball and socket is where there's a disc interposed between the ball and socket right here. That's the source of a lot of patient complaints. It's the cause of clicking, popping, catching, locking in the jaw because this disc can easily become displaced, and it always goes forward. It doesn't go to the side or behind the ball. It always slips forward and interferes with the movement of the ball. When we open our mouth, this is how far the ball moves. You can see there's a very dynamic movement there all the way past the eminence. And so we have a void that's created here, and there's literally a shunt back here that fills this space with blood every time we open and close our mouth so that we don't create a vacuum back here. That makes the joint very susceptible to trauma. Because of the blood that's intimately involved, you can get a hemarthrosis of the joint quite easily, and many of these people do within a year of a traumatic injury. This is what clicking is about. As I mentioned earlier, the disc can slip forward off the head of the ball with the mouth closed, and then as we go to open our mouth, as the ball slides forward, that disc will snap back onto the head of the ball. That's what causes the opening click of the jaw. As we continue to open, essentially it's now a normal functioning joint. But then as we begin to close, just before the teeth come together, there's a reciprocal closing click as well, which is the disc slipping out of position as we close. So every time the mouth's open, this disc clicks into position. Every time we close, it dislocates again. This is a very common condition. 40% of the general population have clicking in their jaw. So obviously, if we had to treat this, we'd all of a sudden have an epidemic on our hands. We estimate only about 4% of patients that have clicking or popping in their jaw really need to have that treated. And I'm going to give you some guidelines here about that in just a minute. So, here's the guidelines. Clicking is only a problem if it's associated with four things. And this is on your handout that you have in your packet. So I think it's the second page of my handout here about when clicking is a problem. So you might want to refer to that as we go through this. So the first condition is if you have pain associated with this clicking or popping, that may be a cause for concern. It may be causing swelling, tendinitis, other problems in the joint. So pain is something we are concerned about. Secondly, if you start developing not the clicking or popping, but more of a locking, catching condition, individuals will often wake up in the morning and have to kind of get their jaw in place before they can open. And what they're doing is literally coaxing that disc back into position so that they can open their mouth. Thirdly is crepitation. That's a grinding, crunchy sound in the jaw. It almost sounds like rubbing two bricks together. People around, if you have this condition, people around you can't hear it, but when you open and close or chew, you can hear kind of this grating condition. That's a much more serious problem than clicking or popping. What that means is that you not only had a locked jaw joint, but it's been locked for so long that you've perforated or torn the ligaments between the ball and socket, and you now have bone rubbing against bone. And if that persists, you're going to start losing bone and develop osteoarthritis in your joint. If that persists and you do lose the bone, that's when this fourth condition occurs where you notice a change in your bite. And typically you'll only be able to touch on one side or the other, or as you close you can no longer touch your front teeth. You can't bite anything with your front teeth again because the jaw position has changed. This is the classification of jaw problems and orofacial pain. And if you follow this dark, bold area here, this is temporomandibular disorders right here, and then a subset of that over here. Obviously, that's beyond the scope of this presentation, but we really have to consider many, many different things as we're diagnosing individuals and examining them to make sure we're not missing something. So what causes this condition? Well, that's where all the confusion and disagreements are about in terms of doctors that are treating this. And what I've done is I've divided all of these associated problems and causes into three categories. One is structural disorders, another is neuromuscular disorders, and a third is psychological conditions. So here we go. This is by no means an exhaustive list, But this is just some examples under each of those three broad categories of what patients are presenting with, what things we have to consider as we're evaluating patients. And the thing that's really, I guess, a challenge, and I really enjoy the diagnostic challenge, but the challenge is that every patient that walks in our door has a different combination of all of these problems. So obviously if you're doing the same treatment for every patient, you're overlooking all of the other components that may be going on for the patient. What we're going to do in this brief time is just look at some examples from each of these categories so that you can, I think, try to appreciate how complex this condition is. One thing is that another way of looking at this is that symptoms in the jaw, at least, really don't occur unless we exceed a certain stress threshold. Each of us has a certain degree of stress we can cope with without becoming symptomatic. As long as we keep our total stress below this threshold, we don't start becoming aware of pain or other problems in this region of the body. If, however, we exceed the stress threshold, we start noticing pain symptoms, maybe stiffness in the jaw, just an overall awareness of this region of our body. The thing I want you to look at is that this total stress can be, again, any combination of those three categories that I talked about: the psychological, the neuromuscular, and the anatomical. This is why there's so much confusion among the profession, because some members of the profession have a bias, let's say, towards psychological issues and think that all jaw disorders are nothing more than a psychological issue. So when they see a patient, they will then focus on the psychological issues, and let's assume they effectively deal with that and lower the patient's overall stress back to where it was before. And if they do that, the patient's symptoms go away and the doctor feels vindicated. He says to himself, aha, it was a psychological problem. Well, maybe, maybe not. Perhaps they're totally missing some of the larger components of the patient's etiology of their problem and really missing the boat. Conversely, sometimes the psychological issues are larger than others. And again, it's who you look at, very much like the blind men and the elephant again, in terms of management and diagnosis. So for psychological issues, I'm not going to get into that. I'm certainly not an expert on psychological issues. I do give screening instruments to all of our patients, primarily for both anxiety and depression, so that if we are dealing with a patient that's got a significant issue there, I can refer them to appropriate professionals. And so I like this quote from Hippocrates: I'd rather know what kind of person has a disease than what kind of disease a person has. Our patients always do better when they're part of the team trying to help. If they just want to come in and say, look, I'm going to pay you this amount of money, so my problems are now your responsibility, that just never works. The patient has to be part of the team, and I very much believe in a self-help effort here. Structural disorders, let's give you an example of that. What's wrong with this picture? Everything's wrong with this picture. Yeah. This is an example of hypermobile individuals. And Dr. Holman very well spoke to hypermobility this morning. Hypermobility is one of the main things that brings patients into our office. It sets patients up for musculoskeletal pain, in my opinion. And these individuals are actually quite young ladies. This one's probably less than 10 years old. When they get on in life, they're going to have major problems in terms of hypermobility causing musculoskeletal pain for them. Trauma is another issue I mentioned. This is a young lady who at 7 years old was an ice skater learning how to do a jump and fell and landed on her chin trying to do a jump while ice skating. Actually did this twice within 6 months and popped her chin on the ice. This picture is 20 years old. This is actually my daughter. And she's now 27, Fortunately, she's missed a lot of the complications. She does have really weak ligaments in her joint and popping and clicking, but hasn't developed a lot of the pain syndromes and locking that some people do. But this is the classical injury that we look at when we take a history. Have you ever had any trauma involving your lower face or your jaw? Falling off your bike, falling off the monkey bars at school, getting hit in the jaw in sports, soccer, you name it. Most of us are lucky if we get through our childhood without some kind of injury like that, and for many people that can set them up for these problems. Parafunction. Parafunction is another big reason why I see patients in my office. It's nothing more than abnormal use of the body. Nothing is necessarily broken. They don't have any broken parts, no orthopedic problems, but they're using their body abnormally. It's simply a tendency, mannerism, or compulsion outside normal patterns of behavior. So let's look at some examples of that. The ones we look at in terms of jaw problems are principally bruxism, which is grinding of the teeth, and clenching of the jaws. Both of these are habits that people have that in 99% of the cases they're totally unaware of them. If you ask a patient, do you clench and grind, they don't have a clue, or they'll adamantly deny that they do it. In the case of bruxism, it only occurs at night during their sleeping hours. And so people virtually never grind their teeth during the day unless they're on certain medications or they have other mental conditions that might cause those kinds of problems. But typically, grinding of the teeth only happens at night. Clenching can happen either day or night. But as I say, most people that do it are totally unaware of it. But clenching activity tremendously aggravates the muscles of not only the jaw, but the neck as well. If we happen to be clenching at night, studies have shown, sleep studies have shown, that we contract our jaw muscles twice as tight, twice as hard as we can when we try to do it to our maximum amount when we're awake. So think of how hard you could clench your teeth if you tried your very hardest, and then double that, and that's what you could be doing in your sleeping hours. Okay? And by the way, the jaw joint is a loaded joint. The studies have shown that on a PSI basis, we load our jaw joints equally to the pressure that we put on our knees and our hips. So a tremendous amount of loading goes on in the jaw joint as well. And bruxism, by the way, has been shown if it goes untreated, bruxism will eventually result in arthritis of the jaw joints. Excessive talking. I have many patients that are school teachers, and bless their hearts, they have to talk for a living. And if they are involved in some of these degenerative conditions, there's virtually no way to keep them pain-free if they're just virtually talking for 8 hours at a time. Or people that are customer service representatives on the telephone, real difficulties helping those folks. Other things are repeated vomiting, either through morning sickness with pregnancy or people that have bulimia. Those folks are just tearing up the ligaments in their jaw joint because every time we vomit, it just really puts all of the ligaments of the jaw joint on maximum stretch. And I'm not going to read all these to you. Stomach sleeping is a big one. If you're having jaw problems, look at the position you sleep in at night. If you're sleeping on your stomach, or if you're sleeping on your side and laying on your hand or something like that, there's a clue why you're having jaw symptoms. This is what bruxism does to the teeth. It literally just wears the teeth right in two. You're looking at the pulp chamber, the nerve of the tooth right here, although in this case the individuals literally killed the nerve of their tooth over the years, so they're not feeling a lot, but that's what the cross-section of a tooth looks like. More parafunction, poor diet, eating disorders, poor sleep hygiene, the working mother. When I listen to the lifestyle of some of the patients that I have, I'm amazed they're able to even stand erect. I mean, they're working 8 hours, they've got 4 kids, they're a single parent, they're trying to get by on 4 or 5 hours sleep at night, and wonder why they're starting to have symptoms. So we're really looking at lifestyle problems for many of these folks. The overachiever. I see too many high school kids that come in that are trying to take 4 AP classes so that they can enter college as a junior. Their lifestyle is writing checks their body can't cash. And so those are things that set them up, the unbalanced life. Another parafunction is poor sleep hygiene. We've already mentioned that. There's a study that came out 2 years ago that showed there's a direct one-to-one correlation between the severity of jaw symptoms and the quality of sleep. And so we need to look at sleep disorders as being a component or a contributing factor of why these patients have these symptoms. Dr. Moldavsky has already been mentioned by other presenters this weekend. He's a physician out of Canada, the University of Toronto, has written many, many reports about sleep and fibromyalgia, sleep and pain. This statement just says that if you deprive someone of REM sleep, that for as long as 4 days afterwards, their threshold of pain is going to go down. They're going to be more sensitive, more susceptible to pain after the next 4 days of being deprived of REM sleep. A night of poor sleep will be followed by a day with more pain, and conversely, a day with a lot of pain will be followed by a night of poor sleep. This becomes a self-perpetuating vicious cycle that we get into. Dr. Gilles Levine at the University of Montreal happens to be a dentist who runs a sleep lab there, who's done virtually all of the work on things like sleep bruxism and things like that for us. Sleep is the big hot topic in the TMD field. There's 3 main societies that focus on jaw disorders among dentists. All 3 of them last year had the focus of their annual meetings being sleep disorders. So it's sort of the discovered problem. This is a book I'd like to recommend to you. It's in paperback. It's less than $20. I think it's like $14, $15. Dr. William Dement is the father of sleep medicine. He was the co-discoverer of REM sleep in the 50s. He opened the first sleep lab in the United States at Stanford in the early 70s. And he's written a wonderful book. It's very readable, but it has all the science and research behind it. He's just a wonderful gentleman. And I'd highly recommend it if you need a resource for improving the quality of your sleep. Okay, here's some statements from Dr. Dement. Ignorance is the worst sleep disorder of them all. People lack the most basic information about how to manage their sleep, leading to a huge amount of suffering. We're not healthy unless our sleep is healthy, and we can't make our sleep healthy unless we become thoroughly aware of both its peril and its promise. When we fail to acknowledge sleep sovereignty over our lives, it has the power to kill. Sleep deprivation is second only to alcohol in terms of highway deaths in this country. It takes a tremendous amount of lives every year, and it has a tremendous impact on the quality of our lives besides that. There is a connection between sleep and muscle pain. Here's the connection. Our muscles can only recuperate, regenerate, what's called anabolism. That can only happen in response to a neuropeptide called somatomedin C. It's now called IGF-1, which stands for insulin-like growth factor 1. Where do we get that? We get that when the liver metabolizes growth hormone. You probably, if you've got fibromyalgia, you've undoubtedly heard about the importance of growth hormone. Growth hormone is produced in the pituitary in response to growth hormone releasing hormone from the hypothalamus in the brain. And that in turn is only released during the deep stages of sleep, stage 3, 4 sleep. So if we don't get into stage 3, 4 sleep, we essentially, our muscles cannot recuperate, even if we're sleeping 8, 9, 10 hours. And so the bottom line is, if we don't get into stage 3, 4 sleep, we're setting ourselves up for muscle pain. Okay? Lake Powell hasn't looked like this for a long time at Rainbow Bridge. This photo is about 20 years old. A physician by the name of Janet Travell, wonderful lady, she spent her life looking at muscle pain, and she is the one that discovered what's called myofascial pain. Now when I say myofascial, don't think I'm saying myofascial. It has nothing to do with the face in particular. But the fascia is what connects the muscles to the bones of our bodies. And she discovered that there are trigger points in muscles, and again, those are different than tender points that you talk about with fibromyalgia. Trigger points are little taut bands of muscle fibers, and those trigger points she described in a two-volume text. She described the pain referral pathways of every muscle in the body. And the thing that's unique about this is that for many of these muscle trigger points, they don't refer to known neurological pathways. In other words, there's not a wire that goes directly from here to here or here to here. She dedicated her life to this. She was recognized for her expertise. She was actually the personal physician to President Kennedy, and she just gave her life to teaching this topic. Unfortunately, she died about 10 years ago before we really discovered the mechanism of why this all happens. And we now know that, which is the topic for a different day. But the thing I want you to realize is that this is called the sternocleidomastoid muscle. It's a strap muscle that goes from your sternum back to behind your ear. And trigger points along that muscle can refer to the face or behind the ear. And then the trapezius muscle, our shoulder muscle, classically refers to this zone. And so we have to be aware of that as to why patients have particular muscles in certain areas when there's no local problem in the area at all. Okay, let's go back and touch on this TMJ, TMD, fibromyalgia connection. As I said, TMJ problems often follow behind trauma, and often that is the case with fibromyalgia as well. Experts have shown that at least a third of fibromyalgia patients have a demonstrated previous traumatic event within 3 months of when their symptoms began. There's a rheumatologist out of the University of Illinois, Dr. Holman mentioned him again this morning, Dr. Muhammad Yunus. In 1988, he postulated a theory that kind of proscribes a kind of a unifying theory for why a lot of these apparently dissimilar conditions may have similar causes. And I put this word possible in parentheses because the jury's really out on this. We don't have randomized controlled trials to prove this, but Dr. Yunus has written dozens of papers for the last however many years it's been, since 1988. I've heard him personally lecture 3 times in the last 10 years at different conferences, and he has a very persuasive argument. Here's his theory. That is, he takes the conditions of chronic fatigue syndrome, post-traumatic stress disorder, tension-type headaches, migraine, irritable bowel syndrome, restless leg, TMD, myofascial pain, and finally fibromyalgia. And he states that all of these are related to a condition he calls central sensitivity syndrome. And what that syndrome consists of are some shared features. Central sensitivity syndrome, and those features include a female predominance. All of those conditions are primarily female conditions. Pain, fatigue, sleep disorders, associated depression, hyperalgesia. What that means is that if something is typically just a little tender if you pushed on it, when you have this condition, it's now very painful, possibly even an electric sensation or a shooting pain that you get if you touch the area. Allodynia is pain when you're touching an area that typically wouldn't be painful at all. And so we get referred pain to other areas that's very troubling for these patients. Plus, we have a neuroendocrine dysfunction. I mentioned the IGF-1, and there's many others that are associated with these conditions. The Journal of the American Dental Association, one of their cover stories in 2000 was this, what's called comorbidity, or association of things like myofascial pain, fibromyalgia, and TMD. There are now many other researchers publishing on this unifying theory, but again, it's just a theory. We don't really understand all the mechanisms of why these folks all have these similar conditions. So what does this mean? Well, one is that these patients are not just stressed out or psychosomatic. Anybody who's in chronic pain, I don't care how psychologically well balanced you are, how emotionally stable you are, you live with pain for 6 months and you're going to be depressed and anxious. Anybody would be. So which came first, the chicken or the egg? That hasn't been sorted out yet. These patients don't fit into nice little cubby holes that physicians like to look at, and dentists. We like to basically group patients either into organic problems or what are called functional disorders or psychological disorders. These problems don't fit into those little categories very easily. TMD, orofacial pain, are just part of a larger medical construct. And then finally, successful treatment of these problems may mean looking at all of these other comorbidities and managing or at least referring the patient so that all of the other problems going on can be managed at the same time. That's frankly what I try to do in my practice. I'm sort of a triage center for the jaw and head and try to work with other professionals that have expertise in their field. I certainly can't treat all of these problems myself. And so that's the way I try to work. Let's look at treatment modalities. I said every patient is treated differently, but there are some very common treatments that are offered for jaw disorders, so let's look at those. On the other page of the handout you have in your syllabus there is what's called general instructions for jaw disorders, and there's 6 things there that we can look at. Physical therapy, by the way, is another thing that we're going to look at. Therapeutic exercises, jaw splints, some medications, and some stress management. But the jaw instructions that you have in your handout, let's go over those briefly. Is everybody there? Lips together, teeth apart. Here's the thing to take home. The only time your teeth should touch, is just momentarily when you swallow. After you swallow, your jaw should relax and your teeth go slightly apart. So most patients that come into my office with muscle pain in their jaw are going around with their teeth together most of the time. So that's one thing you can do to try to help yourself to at least be more conscious of this when you're awake. Not a lot you can do about it at night, but when you're awake, that's something you can focus on that can really be helpful. Avoid any unnecessary use of the jaw. We talked about people that have to talk for a living. That's a problem. People that are in choirs who like to sing, that's very stressful to the jaw as well. I worry about contact sports with some of these patients that have very compromised jaws. So in females, I'm worried about basketball, soccer, volleyball. Those are contact sports. And all you have to do is trip and land on your chin. And if you already got a jaw disorder, that trauma can really set you up for many more complications than someone that never had a problem before. Avoid hard, chewy foods. Basically, we want you to eat normal meals, normal foods. Just avoid the real hard, chewy things. Tough meats, tough breads like bagels, French bread crust. Those are things you need to avoid. Avoid stressful activities. We talked about that. And then get adequate rest. So many, I've done studies time after time, and every time we do a chart survey of how many hours sleep patients are getting, it's about somewhere between 5 and 6 hours a night. That's average. So we have some patients coming in and getting less than 4 hours at night. Very few people are getting 8 hours sleep today, and they think that's normal, that they can get by on 6 or 7 hours sleep. That's really a myth. Finally, tongue posture. If your tongue is in the floor of your mouth, you're really setting yourself up to do more clenching activity and have more muscle tension. Our tongue belongs up in the roof of our mouth with the tongue tip just below, or just behind rather, the upper front teeth. There is a class you can take that I would highly recommend. It's like $55 for the class. It's taught at a physical therapy clinic on the east side, Canyon Rim Physical Therapy. That's the phone number there. It's taught by a physical therapist. I send all of my patients to this class. It's only like an hour and a half one-time class, but they can teach you dozens of things you can do to help your jaw. Exercises, how to breathe properly, posture, therapeutic exercises, just dozens of things you can do. Plus, you're sitting there in a class with other people that have got similar conditions, and I think there's a real benefit from getting ideas from them as well. So what is a jaw splint? Many of you may be aware that's one of the principal treatments that we sometimes use for jaw problems. Here's the indications for a jaw splint. The parafunction we talked about earlier. If you're waking up with jaw pain or morning headaches, that's often because of parafunctional activity of your jaw at night. Or if you have joint inflammation or muscle soreness. Those are all things that jaw splints can help with. The way that a jaw splint works is that you have to realize we've got a very fine-tuned feedback loop that goes on. And if you think of the teeth as, and the brain, let's go to the brain first. If you think of the brain as like a computer, and it has inputs from the teeth. That's kind of the keyboard or the input to the computer. The computer then has outputs that tells the muscles what to do through our nervous system. The teeth are held in the bone by little tiny ligaments. And those ligaments have mechanoreceptors in them that are very sensitive to how our teeth touch. And that saves our bacon, because when people, for example, get in the habit of crushing a piece of ice between their teeth, they have to exhibit thousands of pounds per square inch to crush that ice, and yet the instant the ice breaks, their muscles immediately release and their teeth actually don't touch. It's that finely tuned of a system. But on the other hand, if we have a significant problem in how the teeth mesh together, what we call a premature contact here, that's a constant barrage of inputs into our computer and outputs into the motor nerves, and we have constant tension here on the muscles of the jaw. The jaw joint is sort of the focus of all of that tension. And so what a jaw splint does is simply break up the inputs to the computer and neutralize this cycle, this feedback loop, if you will, by getting rid of those kinds of problems. So that's the theory. There are some problems with these devices. For one thing, they are expensive, and so that's a problem, and some people try to get, the cheapest splint they can get, or they go to the hardware store or something and get something they put in hot water and try to work with that. I'm sort of biased against those. The wrong type of splint can literally do more trouble, cause more problems than it solves. If these devices aren't made properly, here's some of the problems. If they're too tight or too loose, you're going to end up clenching on them all night just to keep them in place. If they're too thick, they're actually going to exceed the freeway space, the neutral zone of your muscles, cause more muscle problems. Lower devices tend to move the teeth quite readily, so after wearing one of these devices for a couple of months, and you take it out, and all of a sudden you can't touch your teeth anymore because your teeth have been moved apart and pushed into the bone. So these can be potentially dangerous devices. They can be just another bad bite that causes more stress to the muscle system. Soft splints, they're sort of the popular thing right now, but these rubbery types of soft splints, EMG studies at night show that patients actually sit there and grind and clench on those more, and it makes sense. I mean, the brain thinks that's a piece of steak it's supposed to be chewing on, so soft splints don't work very well at all. Being worn too long is a problem. If these things are left in for too long, and I'm talking about years now, if they're not supervised, which is my last point here, they can lead to more cavities in the teeth, gum disease, move the teeth, as I mentioned. So potentially they can cause real problems if they're worn unsupervised. Questionable treatment. What I want to do is sort of giving you some red flags to look for if you're talking to doctors about these problems. Because too many doctors treating these problems have one pet treatment, and they try to make all their patients fit into that pet treatment. For example, some dentists get involved with jaw patients because they want to do braces on them, and what they really want to do is say they're going to treat your jaw and then put you in braces for $6,000, $7,000, $8,000. Or on the other hand, their motivation for treating your jaw may be that they want to cap all of your teeth. And we have dentists here in Utah that their jaw treatment is a $45,000 treatment to cap all of your teeth. That's rarely necessary to cap any of your teeth. I don't do any dentistry myself. I haven't picked up a dental drill in 15 years. But it's rarely necessary to do that. So if somebody's recommending either of these as the treatment for your jaw problem, I wouldn't walk away, I would run away. I wouldn't allow a chiropractor to manipulate your jaw joint. I don't know anything good that can come from that other than damaging the ligaments of your jaw joint. There are some dentists that will tell you that the reason you have fibromyalgia or chronic fatigue is because you have toxic levels of mercury in your system from your silver fillings. There's absolutely not a shred of science to support that. You see, the problem with fibromyalgia and chronic fatigue is these folks are very easy to take advantage of. They'll do anything to do something to help their symptoms. And so they get sucked into some of these treatments that are sometimes actually harmful for them. Anyone that treats all jaw problems the same is sort of a red flag. And so you want to make sure that whoever you're seeing is spending more than 10 minutes diagnosing your case before he recommends how to treat your jaw. TMJ surgery. I only recommend surgery to 4% of the patients that I see. And I'm seeing the worst patients in this part of the country. We see patients from 5 states. And of all of those patients, I only recommend surgery to 4%. Surgery does have a place, and there are certain criteria that need to be made. One is obviously pain that can't be alleviated any other way. But if their problem is actually too severe, if they're already into arthritis, they've already got bone loss, in my opinion, surgery is not an option for them because they have tremendous complications after surgery. Surgery on those folks will generally accelerate the bone loss, cause tremendous scar tissue formation in the joint. That's something we will not do. So those are some of the criteria. You want to choose a surgeon that does this surgery every week, not somebody that does it twice a year. You don't want to be a learning experience for some surgeon. There is an absolute necessity for rehabilitation after surgery. If you have jaw surgery, your jaw's not wired shut. We're trying to do everything we can to get it open again, and you have to have appropriate rehab, which takes about 3 months of seeing a physical therapist twice a week to get your jaw back to a normal range of motion again to avoid those adhesions and things that try to form in the joint. You do have to wear a jaw splint full time for that 3-month period, and be aware going in that when they do surgery on the jaw joint, that is going to change how the jaw hinges, and there probably will be a need for some type of bite treatment after the surgery, but again, rarely does that involve things like capping all of the teeth. Okay? So, we're done about 5 minutes early. Is there any questions? Yes? Oh, good question. Do orthodontics cause jaw problems? If you'd asked me that 15 years ago, I would have said maybe. The way orthodontics used to be performed by orthodontists really did kind of set people up for a problem. And I won't comment on that beyond that, but the answer today really is no. Most of the orthodontists that cause jaw problems are now retired. Because the techniques, the methods they use to move the teeth are no longer used. Yes?
Do you know if this Kenyan room physical therapy and anything else that you might find by the center or Medicaid?
You'd have to call that number. I can't tell you if they are or not.
Do you know if there's other possible treatments that can possibly be covered by Medicaid?
I don't know. Insurance is my biggest frustration in my practice. And that's not just me, it's not just here in Utah, it's a national problem. I estimate that certainly no more than 20% of our patients get any kind of insurance benefit for these problems. Most insurance companies, including the big 800-pound gorilla here in Utah, IHC, have a specific ironclad exclusion clause dealing with anything to do with the jaw, regardless of whether it's arthritis, no matter the severity. It's almost hopeless. And I write letters. You know, I spend probably a third of my time in the office dictating letters, and I have to tell you, it's pretty hopeless. Yes?
Would you explain a little more about oral facial
Okay, she's asking would I explain more about orofacial pain and the difference. That's another hour lecture. Orofacial pain has mainly to do with things like headaches, for example. It is true that we do help a lot of headache patients just by what I've described here, but certainly migraines are a different phenomenon. That's a neurovascular condition. But there are other things like trigeminal neuralgia, postherpetic neuralgias where viruses have damaged nerves. There are problems in terms of sympathetically maintained pain, and those are really sort of esoteric problems. They're not a big part of my practice. I'd say only somewhere between 10 and 20% of my patients have these neurological conditions. But one thing I can tell you is that a lot of people are working on this right now. The part of the brain that controls all of these, migraine, tension-type headaches, these neuralgias, neuropathies, deafferentation pain, unfortunate surgical complications from dental procedures, pretty much all of those are controlled by a part of the brain that has to do with the trigeminal nerve, which is the nerve that controls all of our mouth, our jaw, everything in our head virtually. And there's a tremendous amount of basic research being done on that. The trouble is that everything they've found in terms of medication has tremendous side effects. There's a drug called ketamine that works really well as an antagonist to this system, but it's called vitamin K on the street. I mean, it's a drug of abuse. Dextromethorphan used to be used in cough syrup. It's been taken off the market, and so there are some new things coming out, but we really are still searching for the magic bullet. On the other hand, I can tell you that many patients are helped by what are called neuroleptic agents. You might have heard of the drug Neurontin, as well as the older antidepressants, the tricyclics. We really have, I think, really good results for most of these patients with combinations of tricyclics and the neuroleptic agents. But that's really, in general, all I can really say. I'll take one more question. Anybody else? Yes?
I saw something on the news the other night about a little splint that you wear right in the front.
Yeah, the NTI device. This guy makes the hair of every neurologist that treats headaches stand on end. This is a dentist down in Southern California that tried to patent a device I've been using for 25 years. It's just a little plastic device that fits on the front teeth. And what he did is he took 15 patients that supposedly had migraine, gave them this device, and 80% of them got better. Any scientist can tell you that an N of 15 is nothing in terms of research, but somehow he slipped this past the FDA. And it's troubling to me because if a person wears this device, it has all of those complications that I mentioned about problems with jaw splints. I can guarantee you if you wear it for more than a couple of months, your teeth will move, and it's not a panacea. But it's making a dentist in Southern California a lot of money. Okay, we're going to have to leave it at that. If you have other questions, feel free to come up, but we need to, I think Dr. Bateman comes in here next, is that right? So we need to make room for her. Thank you for your time.